like to thank Dr. Ramesh Babu sir and Dr. Vikesh sir for this session, Challenges Faced by our Pediatric Surgery Residents. We have an exhilarating sessions of AI in pediatric surgery, but now we are coming back to our basics, that is our pediatric surgery residents and what are their challenges. It is very heartful to see still in 2024 when we are discussing AIs, we are having challenges that are faced by residents. We did a survey to find out what challenges they are facing in their daily academics life and pediatric surgery life. So this is the results of the survey. So I would like to tell you we have 133 MCH and DNB pediatric surgery seats as of now in India, and almost 80% of the students are there, amounting to around 105 students. And out of 105 students, we got response for 65 students, that is amounting around 64%. And the first question that we asked those students was pediatric surgery was their initial option of choice. You see, only 33% students, only 30% said their initial choice was pediatric surgery. If the residents who are doing pediatric surgery itself are saying they are not interested in pediatric surgery, it means we are lacking somewhere. Either pediatric surgery is not a lucrative option, either they are not knowing about pediatric surgery, they don't know what pediatric surgeons do. So we have to look in all these things. Another important questions we asked was the factors influencing their choice of college and institutes. As we all know, when we are doing any UGs or PG or MS things, the most important thing we want to know about the exposure and hands-on training. So this comes first, and almost 63% of the participants told their primary factor was hands-on training. Another important factor was the popularity and recommendations. So whatever college these MS people are going, basis of their seniors and their popularity of the colleges. And are you satisfied? The next question is, are you satisfied? So you see 60% of the students said they are mostly satisfied but not fully satisfied. 10% of the students said they are not satisfied at all. So if you see 70% of the participants are saying they are either mostly satisfied or not satisfied. Completely satisfied are only 25% of the students. Means whatever colleges they are in, whatever good institutes they are in, we are saying we are very good institute, but our residents are not satisfied with us. And the most significant challenge. So you see 37.5%, they are saying balancing academics with the clinical duties. That is the most significant challenge they are facing in their daily to daily life. Workload, as we people say, there might be a workload challenge residents are facing. Only 14% residents are saying the workload is an issue. Workload is not an issue in pediatric surgery. The issue is balancing academics with the clinical duty. And the other important thing that they are saying is lack of hands-on experience. Almost 20% are saying they have lack of hands-on experience, and 20% are saying lack of guidance from seniors. So 40% of the people saying they don't have any guidance or they have no hands-on experience. How much they work? So 10 to 12 hours. 66% of the participants are saying they are working 10 to 12 hours or more. This is about the transition. When a person is doing MS general surgery and now they are going to MCS general surgery, there is a frame shift from having those heavy instruments to those delicate instruments, to retracting it too much, to retracting it too less. So how they are facing? They are taking time, but they are able to manage. So this is how they have rated hands-on experience at their colleges. So most of the people, 60% said they are around 15 major cases in a year. This is about in a year. And the minimal invasive surgery. So in last 3-4 days, we have so many papers, we have so many sessions on minimal invasive surgeries, robotic surgeries, everything is there. But what our residents are saying, You see, 44% are saying they are only assisting. They don't get any hands-on for minimally invasive surgeries. And 35% they are saying they are only doing basic procedures like hernia, UDT, or appendectomy, amounting to almost 80%. So whatever we say, our residents are saying 80% of them either only assisting or doing basic surgeries. They are not doing any thoracoscopies, they are not doing any good surgeries. We have a session here today in the morning about the preparation of cases, preparation of surgeries. So what our residents are saying, they 40%, 47.7% are saying they are only having a team discussion within the senior guidance. They don't have any facilities or any discussions with multiple specialties. Whenever a complex surgery is planned, I know at my institute, we were discussing with the team of radiology, were discussing with the team of pathologists, what sample to send, when to send, and after sending samples, we were going to pathology department to see what is going on. But only 47.7 percent are doing with their senior guidance, not with other departments, and only 29% are doing with other departments. Minor surgical procedures, yes. 75% of the residents said they are actively involved in as primary surgeons in minor surgeries. Academic programs, now we are having an academic feast here in IAPSCon, but how our residents are rating their academic programs at their institutes. So non-uniform academics are there in 33%, as they said, while regular seminars are there in around 50% cases, but without feedback in 30%, and with feedback only in 36%. And the interdepartment academic collaborations, no collaborations at all in 32% of the answers as we see, and needs to be initiated by individual residents or students, it is 24%, amounting 50%, almost 50% of the residents are saying there is either no interdepartment academic collaboration or either they only have to start. Research culture. So we were discussing with the AI how you are going to do research, how to write manuscript, how to deal with the papers and all. But what our residents are saying, you see, 42% said they only have case reports or observations, and 42% are saying they are only focused on thesis related. So out of 100%, 84, 85% are saying they either doing case reports or either focusing on thesis related. Nobody is focusing on what the actual research is, what the research culture is. Either they don't want to do or there is some lack, I don't know. So this question was, what was the lacunae? So about the exposure of research methodology and scientific training, you see in 71%, they said either they don't have exposure or very limited exposure or occasional guidance only when asked. So how many papers our residents has published? Most of them said either one or not at all. So this is about the clinical acumen. So exposure to their subspecialties during their training. As we know, most of the pediatric surgeons are actively involved in pediatric urological cases also. So broad exposures in there in 44% of the cases that they said, but very limited exposure was also there in almost 20% of the cases. Now when we came to pediatric surgeons, what define us better than any other surgeon is managing our neonatal surgical emergencies, managing our neonatal cases. And if a PG coming from a good institute, either it can be AIM, CMC or Leelavati Hospital, they are not able to manage neonatal emergencies, then it is not counting to be a good pediatric surgeon. And what our residents are saying after passing their MCH, after coming into practice, whether it is a private practice or government practice, most of them are saying 73% they are confident, but not such confident they can manage it alone. They are just saying either they need more experience or either they need guidance. Trauma cases, only 27% of the residents said they are able to manage or they are very confident in managing pediatric trauma cases. How prepared they are. So you see, around 90% of the residents said they are somewhat prepared, minimally prepared, or not prepared at all. Only 9%, only 6 people out of 65 said they are well prepared to do complex congenital surgeries. Exposure to pediatric urology, as we are practicing pediatrics surgery along with pediatric urology, almost 66% of the residents said they are able to, they are having good exposure in pediatric urology. The relationship with the senior faculty in the department, most of them said very supportive and approachable senior faculties. And when we ask, how do you feel about your residency program? Are you prepared adequately by your institute for an independent practice? Most of them said, you see, around 80% said they are somewhat adequately prepared. Only few, only 20 said, yes, I feel fully prepared. So this is the era of AI that we were discussing, but about the surgical equipment during training, 58% of our residents are saying it is occasionally unavailable but manageable of the surgical equipments during the training. Stress of long working hours and patient cares. So they are relying on supports of colleague in 38% of the cases, while good personal coping strategies are there in 32% cases. So good work-life balance, only 9. Out of 65 respondents, only 9 said, that is 13% said they are having a good work-life balance. So they don't have good work-life balance too. Mental health support, only 7%. 93% don't have mental health supports in their institute. Experience of workout. You see, workout burnout, it is there in 86.2% cases. And what specific changes we have asked they want in their institute or in their residency experience to be better. So 40% of the residents said they want more hands-on training opportunities. What other 25% said? Better work-life balance. What others said? 17% they want to have good research and academic opportunities. Overall satisfaction. So you see, very satisfied is only 20% out of the 100. Receiving training for minimal access surgeries. We were discussing about the simulation, OR, AR, VR and all, but our residents are saying in 73% of the cases, they are directly doing on the patients or they are not doing at all. So once they came to this pediatric surgery journey after completing their residency, have they received any guidance? What they are saying? They have not. Only 9 out of 65, that is 30%, receive good guidance or extensive guidance. So I think this survey is an eye-opener for all of us. We have to look backwards. We have to look to our newborns, because as we say, when you are coming to a pediatric surgery, you are doing a residency, you are a newborn, and pediatric surgeons, pediatric urologists are well known to be a best caregivers for their newborns. So we need to have this care for our newborns so they can go into market, they can go into to be a good pediatric surgeon and take a pediatric surgery and pediatric urology way forward. Now I would like to ask our experts to comment on this survey and what we can do better.
Thank you, Dr. Rahul and Pooja. Done a very good job. Few things that I have in mind. See, when I took this is a personal thing. When I took a pediatric surgery after finishing my MS, general surgery, in PGI, that was about maybe 35 years back, okay? It was so tough. It was so tough. I just cannot tell you, especially the general surgery training. We were not even allowed to go, even as girls, when we had our difficult days, to go back to the hostels. We survived through it all. Nobody asked us about our mental status. Nobody asked us whether we had breakfast, whether we were working 8 days or, 8 hours or 10 hours. We were there 24 into 7. Then subsequently, we rotated through all the places. And I chose pediatric surgery because I was very fond of it right from the beginning. That's a different story. The mentors, Dr. Kale and Rao and Dr. Mitra, I loved their work and I loved babies. That's a different thing. Okay, so I mean, why for the first thing I wanted to ask, why are we talking so much about the residents and their concern now? We don't have MCH students, 3-year students coming to us anymore who have gone through the grilling of general surgery. We have directly the neonates, our neonates who are sitting there, fresh pass outs, 6 years courses coming into pediatric surgery. I know they are young, they do have problems, but don't they want to take the risks and difficulties in life and tackle them on to become good surgeons? Why should they be working for 8 hours only? Why should they have nights off, day off? I'm sure they should do it, but I think we are going overboard. They need to be better prepared as surgeons. I mean, this is my personal take.
Yes, ma'am. Yes, we do agree with this statement. What is the general consensus is that it's not like the resident has to bear the whatever the overwork or the overworking hours or the grunt work, anything, everything. Resident has to be ready mentally, physically to take all the risks, all the challenges, so that they can become a good or the best surgeon if possible, to treat the patient, to provide the best optimal care. But the thing is, in this era of the artificial intelligence, too much modern technology, where we have to fight or where we have to challenge the artificial intelligence, where we have to make a foothold for ourselves, it's better or it's best for the resident and for the pediatric surgery as a broad specialty also, to create the optimal conditions so that, and yes, president and the consultant or the seniors, each has to be like supportive to each other so that they get the optimal, you know, uh, outcome. That's what we want the best for this questionnaire also. That's what we were choosing for.
Madam, one thing I would like to say, as you told, you chose pediatric surgery 35 years ago and the extensive training and all were there. I just want to say one thing. Madam, I know my parents used to say when they were going to schools, they used to cross rivers, they used to go on cycles for 35 kilometers. That was their struggle. And through that struggle, they came to a graduation level, they did job or business, whatever. Then came to an era where we have to go to school. And my parents used to provide us buses or car or tempo. We were going to school in all those luxury. But going to school was the mandatory thing. And teacher used to beat us even with some whatever we are doing. If we are doing any mistakes, teacher used to beat us. Now came the next generation, generations below me. Now if you say anything to that student, now parents came to the teacher and teachers can't say anything to them. So their nurturing is going way forward. Now the next generation, that Gen Z is coming, you can't say, even as parents, you can't say anything to them. If you go to Canada and US or in Norway and Denmark, if you said anything to your child and child can call the child support system, you will be behind the bars. So that thing is going in India also now. So if a Gen Z resident is coming to that training institute where they have been nurtured by the parents, by the teachers, like he's very soft-hearted, he should not be treated like that. And once they came into residency and they feel they are being pushed through their boundaries, they will definitely feel burned out. So that is the issue currently that is going on. I feel it is, ma'am. So we as a teacher or we as a mentors also needs to actually see why they are feeling burnout, because for 20 years they have been nurtured through that different things, and now in a residency, they have been going through different settings. I feel this is the issue.
See, I just thank you for giving nice your report. I just saw and see there are many issues. This is not from one end, right? This is the problem of the resident, problem of the faculty, and problem of the institution.
100%,
These
sir.
three levels are the problems, and
100%.
the last problem is the government. The most important thing is that the interest of the resident, which you have shown 33% resident, they have interest in pediatric surgery. The reason is very clear. The reason is that this branch, as compared to other super specialty, is not as paying as other branch, number one. Number two problems is the placement. Once you will out from the residency, you don't have a place in the government sector, even medical college, institution, district level, they don't have seat for your placement. That is the another issue going on, which we have talked the day before yesterday in my inauguration also. And third thing is, residency means you work for 3 years and happy for 30 years. That is the concept of the residency. And if I remember what madam had told, it's 100% true, that what is the meaning of 8 hours job, what is the meaning of 12-hour job, what is the meaning of 24-hour job. You must enjoy your work and stay in the ward or hostel, both are in the same place. So why you people are saying that we are working 24 hours and in a day and not getting time? This is not so anywhere, even in the my department in KGMU, I have given full freedom to the resident. You come at a daytime and work, and then alternate you go and take a sleep. What is the problem? And if you have any issue regarding your personal issues or departmental issue, say we have a committee in the department to talk and we will try to solve your problem of any kind. So I think mentoring and parenting both are required by the departmental level. I cannot say only mentoring, but parenting is also very important. That every faculty consultant should work like that. They should not. And third thing is specialty rotation. Yes, it's most important. Every department have their sub-specialty, and residents should rotate every 3 months, 4 months, 6 months, depending upon their situation into various this section. So, and exposure, see, there is a SR1, SR2, SR3. There is a training. If you go in the roof, then you have to go first step, then second step, then third step. Now the resident is coming, and it's different than when I was the resident. And they initially try to get the start this laparoscopic and everything. So you start with open surgery, make your concept clear, and then one by one with cystoscopy, then laparoscopic, then procedure. You expect like this, then it's okay. But if you jump to the without open surgery to the laparoscopy, is not fair enough. Your thinking is also in that way.
Yes,
So
sir.
this is what my concern is.
Sir, I agree, but in a part basically, you see, when a MCH resident is coming, SR1, SR2 and SR3, as we were talking, he came after doing a surgery basically, laparoscopic. He have exposures of laparoscopic surgeries, normal surgeries. But when a SR1 is coming in pediatric surgery and he is not been giving any exposure in laparoscopic surgery, as we say, he was almost all SR1 in pediatric surgery where MCH is there. They are doing all ward works, ground works, paper works and all. Then they are going to be a SR2, and in SR2 they have been involved in cases directly. They've been doing all the they've been assisting all the cases. They are doing minor cases, and when they are going to be SR3, they are going for the preparation, examinations and all. In between all these 3 years, the basic laparoscopic surgeries, basic minimal invasive surgeries, and as we are saying robotic surgeries, they are missing those components. And when they are going to be in private practice, all of a sudden, all the patients been asked them the laparoscopic surgeries. So I think we have to say when SR1 has to start minor laparoscopic surgeries, when they can be upgraded to do a
Can I say something? After finishing MCH also, on the same point, sorry to interrupt you. On the same point, after finishing MCH also, we need 5 years to get to that level. If you expect that you will learn robotic surgery, I'm all for you guys. I was going to actually say a few points, in your favor, but this particular point, I do not agree. There's a learning curve. You have to spend some extra time on that. You cannot expect to be an expert. And what our survey shared, that, all we got was hernia and oculopexy. But that is what you will get. That is what you'll get. Now, the other thing about, the training hours for MCH students, right? So, unless you are there in the ward 24 hours, you will not learn. So, we've been like Dr. I joined surgery when there was no surgery resident. So, I mean, I was the only surgical resident in my whole thing. So, I thought I will have a lot of, even discrimination. Okay, oh, she can't do this, she can't do it. But I survived through it because I did everything. So, we have to be strong. And when we are dealing with small children, we have to be emotionally strong. So, that choice is very important. At the same time, I feel there are going to be long work hours, but you should get some small rewards. We as faculty, we have to kind of, take care of them as our own children. We have to make sure that they're not, at the brim of, if somebody needs a break or somebody wants a leave, those problems sometimes happen. You don't have people in the department, there's so much workload, you are not getting the leave. And also we appreciate that especially the post MS surgery residents, you may be having your family at that time and you may have those troubles. So you have to balance it, and that is part of the learning. But we as faculty, I know off late I'm not in the teaching, but I do see the DNB residents in my institute, but I've been for 8 years in MAMC. So we as faculty, we nurture them, you do the hard work. In return, you get help in writing a paper, you present papers, then you feel accomplished. You don't feel that you're just being used for the paperwork and all. And I think most of you are so savvy now. Many institutions have all online notes and all that. You guys do it better than us. We have to learn that. You guys are already expert in that. So there are various methods of decreasing your work as well.
Thank you, madam.
So I,
Ah,
in short,
okay, sir.
like very 3 points. One is cutting work, amount of cutting work. See, that is the prerogative of the head of the department. So a resident cannot demand that. You have to deserve that. You do extra work, impress your HOD and get the cutting work. Second thing, there are certain deficiencies in certain departments. Every department is not complete. There are certain specialties which are not done so profoundly in certain departments. So here the responsibility maybe of the HOD, that he may allow some exposure to the resident at some other place, either in the form of conference, workshop, or a short visit to his friends who is doing that sort of work. And third is onus is on you. After 3 years of MCH or whatsoever, no one is perfect, like madam said. It is a continuous process. So extended residency, what I call is after 3 years of MCH, it is extended 3-year residency when you work and actually you learn then. So 3 years, it is a foundation which HOD gives you or professor gives you. So on that foundation is strong. So believe in that foundation and work harder another 3 years, and I'm very sure you will get all the opportunities.
Yes.
Thank you.
Sir, just my 3 points on this. The way we had prepared this questionnaire, we want to show the house and also both the consultants and the residents. Yes, sir, I do agree. The onus is on the resident ultimately. No one is stopping us from learning. It doesn't mean that, as sir said, SR1 is not doing anything and straight away SR2 is given case. So what is stopping SR1 from practicing? If they do practice, if they do watch videos, many consultants are, posting the videos online where all the seniors who have learned the laparoscopy, robotic surgery after like 30 years of this practice, they are also learning. As ma'am said, as sir said, we are continuous learners where we have to develop ourselves, where we have to finance, these financing these skills and all such. Yes. Second point is, yes, again, the onus is on the resident also to ask for help, to modify their schedules, to take a break, to request what do they need, or to feedback, take feedback, give feedback, and all such. And yes, third point is again the onus is on the resident. If we choose the department or if we are getting this branch, it's our job as a resident and also as a consultant to do the work, to enjoy the work. What can we do to enjoy the work, to make it enjoyable, or where we are lacking? Again, give the feedback, take the feedback, whether it is constructive feedback or the criticizing feedback. It's on all of us ultimately. That's the goal of this questionnaire. We want to show the house what is the mindset of the residents. Yes.
Pooja, we already know the mindset of the residents. Maybe next time, Vikesh, to be on the hilarious side, I think you need to take a questionnaire from the faculty. Okay, put it up. We'll all answer and let's see how it goes and get the children on the stage. Let's all have a practical discussion between the two of us then.
Then that's a never-ending debate.
Absolutely.
That's a never-ending.
What I feel that world has advanced, but learning skill will take same time what it takes 25 years back. So you have to be patient. First 6 months, we used to learn just to put cannula and withdraw blood. That was the achievement in first 6 months. So you have to enjoy that also.
The last comment from me, Dr. BK sir nicely told that many centers, they have some deficiency of certain things like they have not very tuned for laparoscopic, they are not very, they don't have institute of robotic. So what they can do that, there is a interinstitutional observations by the resident to the other department. They can also improve their skill and other things, which I have started with Dr. Basant for robotic surgery in SGPGI for few week or few month rotation as a observership, and something like this we can also go ahead and we can do the interdepartmental or interinstitutional this observership for the benefit of the resident. That can also be done.
I have one question to residents, sir. Because they are resident representative, I am one of the resident representative, but I have question also. This session was arranged for residents. Why they are not there in the audience? See, this is the biggest hurting question.
Sir,
This is what I wanted to ask.
Yeah, so see, this today's all sessions are oriented towards youngsters and residents. And yesterday I put request that I worked so hard for all of you for 1 year. Only thing which I need in return is you be present in the hall tomorrow. So this is something which need to be improved from resident side so that we continuously keep working for you and similar sessions get organizing next year onwards also.
100%, sir.
It should not be disheartening to the organizer. The residents are not there only in the sessions for which they are directed towards.
Absolutely.
So one thing I can say, sir, for this, I know few of the institutes where a resident is there, their paper got selected, but they got leave for only a day, for a single day. I know the institute's name, I'm not taking it, but they get leave for 1 day, you have to go, you present your paper and come back, do your duties. And the other thing,
So I think
We should defend them, but when they are wrong,
100%, sir.
so that is the job of a teacher. So teacher should not be like pleasing teacher. Should be straightforward teacher. When it is wrong, it is wrong. When you have done good, I'll clap for you.
This is same that you want to come in the OT, but you don't want to work in the ward.
Yeah, exactly. So
I think
it's a never-ending debate. It is nothing against anyone, but professors are nothing without residents. See, all our acknowledge or credit, whatever good happens to our patients is because of residents. We always give credit. Yes.
I think time is over, and I thanks to organizer for this opportunity. But one thing I would like to say, there will be good relation between the resident and the faculty, and cooperate to each other. That is the good way you can run the residency. And you don't think that that residency scheme is your punishment duty. It is basically your workplace for 3 years, and you will enjoy rest 30 years. Thank you very much.
Thank you.